So thanks very much for asking me to speak tonight. I'm going to kind of carry on from Caroline's talk really about amyloidosis in relation to the nervous system. So I'm a general neurologist, but I also have an interest in nerve and muscle, which is where the interest in neuropathy comes. And I don't want to assume knowledge, because often I'll see patients and they'll have been told by the referring neurologist or other specialist that they have a neuropathy, and I'll kind of start talking to them in technical chat and mentioning the word neuropathy, and I meet a blank, face saying, I don't know what a neuropathy is. So I think it's important to know what we're talking about. So as neurologists, we're interested in the nervous system, which is made up of the central nervous system, which is your brain and your spinal cord. And then the peripheral nervous system, which is what I'm really interested in as a neurologist. And that's made up of all these kind of long, kind of branch-like projections from your spinal cord to your muscles. So those are called nerves. And the nerves are made up of different types of nerves. So you have motor nerves that go to your muscle. So when you want to move a muscle, an electrical response basically travels from your brain down to your spinal cord and then down to the individual nerve to supply that muscle to get it to move. And then vice versa, we have sensory nerves that relay back sensory information. So like touch, joint position sense, balance. So if you're standing up and you close your eyes, if you don't have a neuropathy, you should be tickety-boo and absolutely fine and not swaying. Where if you have a problem with the information processing coming through from your joint position sense, often patients will say, I can't actually even have a shower because when I close my eyes, I fall back, I'm unsteady. So you can think of nerves as being including sensory nerves and motor nerves, but also in addition, there are these automatic or autonomic nerves as well that kind of carry out lots of really important functions, but they're not nerves that you would kind of on purpose instigate a reaction. So they're nerves that control things like heart rate and blood pressure, bowel control, and I'll come back to that later. So there's different types of nerves and neuropathy. So sometimes neuropathies can just attack one particular type of nerve. So a sensory neuropathy is where there is damage to the sensory nerves. And that can be either what we call a small fiber sensory neuropathy or a large fiber sensory neuropathy. And I'll talk a bit about what's this length dependent process. So this picture here illustrates a model here with a different color blue illustrating a glove and stocking distribution, which is something that we talk about quite commonly in neurology. And what that really reflects on are the symptoms of a length-dependent neuropathy. So if you think about nerves, you're talking about the same individual process that leaves your spinal cord, that goes all the way from your spinal cord to your feet. So this is the same process. So they're really susceptible to things like, dietary deficiencies, so vitamin B12, vitamin B6, deficiencies can cause a neuropathy that's length dependent. So it starts at the edges and works its way up. So that's why patients often present with neuropathic symptoms in their feet first. And those neuropathic symptoms can be a loss of feeling or an actual hypersensitivity of feeling. So pins and needles, interpreting non-painful sensations as being painful, feet feeling hot or feet feeling cold. And often what happens is that these symptoms start, you're very kind of tippy toes, and then they travel upwards more kind of proximally closer to the body. And often by the time they've reached patient's knees is when you'll begin to see symptoms in the hands, because that's kind of a similar length of nerve fiber that we're dealing with, to the knee. So a sensory neuropathy will often cause these length-dependent sensory symptoms. And I've put in small fiber versus large fiber. So we can talk about how we pick up neuropathies. And we do that by looking at nerve conduction studies, and I'll come back to that later. But it's important to know that nerve conduction studies only really show the electrical responses of large fiber neuropathies, which can present with the typical neuropathic symptoms that I've discussed, and also problems with balance. So these are the patients that will, for example, at night, they would have to turn the light on to go to the toilet, or else use their hand to kind of guide them along a wall, because not having that visual input, they would be relying on their sensory nerves more, and because they have a sensory neuropathy, they're more unsteady. Now, with a small fiber neuropathy, this is much more difficult to diagnose than a large fiber neuropathy, because these patients will have a normal set of nerve conduction studies, but they often present with the same kind of length-dependent, painful sensations that can be really difficult to treat in the neuropathy clinic, but also very difficult to diagnose. And traditionally in clinics across the world, skin biopsies are performed usually at 2 sites, in the distal lower leg and in the thigh, and then the actual nerve fibers are counted and compared to a set of normal controls or healthy controls. Now, the issue is that this is a very labor-intensive diagnostic test to do, and not many labs in the world do this. So in the UK, there are 3 centres, 2 in London and 1 in Oxford, and they all have different numbers of healthy controls to compare to. Researchers in Italy have compared their results to other centres in the world, and you don't necessarily get good concordance of your data. So we don't have a good diagnostic test, I suppose is what I'm trying to say, for a small fiber sensory neuropathy. So moving on to a motor neuropathy. So we talked about how motor nerves are the nerves that supply your muscles. And some patients can present. This is actually a patient who has an inflammatory neuropathy, and there you might be able to see in the forearm there's wasting, and also there's wasting in the hand muscles as well, between just below the fingers. And this patient doesn't have a hereditary amyloid neuropathy, but amyloid neuropathy can sometimes present with a motor predominant clinical picture. And then you can have a mixed sensory and motor neuropathy. So this is actually a patient with a different type of inherited neuropathy. This is called Charcot-Marie-Tooth, which affects sensory and motor nerves and starts at a very kind of earlier age. We can also see what's called mononeuropathies, and actually carpal tunnel syndrome, which has been talked about earlier, is a form of mononeuropathy. What's illustrated here is the patient sitting with his elbow or with his arm overlying let me just go back, the chair, and that's causing compression of a particular nerve called a radial nerve. And the radial nerve allows you to bring your wrist up, and he's developed wrist drop. In fact, this particular palsy is known as a Saturday night palsy, because it's been reported in patients falling asleep perhaps on a Saturday night when you've had a bit too much to drink, perhaps, or you're a bit fatigued. And these type of neuropathies, by and large, will improve with conservative measures. And then there is this autonomic neuropathy. So the way I think about autonomic nerves is that these are the kind of automatic nerves that control these involuntary bodily processes like blood pressure, digestion, and bladder control. And there's already been a bit of chat about autonomic symptoms to be aware of. And I think the issue with autonomic symptoms is that they can be attributed to lots of other different conditions. So, somebody presenting with diarrhea or constipation and bloating could easily be attributed to irritable bowel syndrome. We've had a patient in Glasgow who had intractable nausea and vomiting and loss of appetite and massive weight loss, who it wasn't until the cardiac side of things were noted that the diagnosis of TTR was made. And also medications can cause a lot of the symptoms as well. So erectile dysfunction can be a feature of blood pressure lowering medications. So it can be a difficult diagnosis to make, the diagnosis of an autonomic neuropathy. And also, how do you make it? So, autonomic function tests can vary from department to department. So when I'm sitting in the neurology clinic, and I'm being presented with a patient who either the GP suspects neuropathy or they've had nerve conduction studies that's given us a diagnosis, I'm thinking about all the possible causes of neuropathy. Now, by and large, worldwide, the biggest, most common causes are things like diabetes, alcohol, and vitamin deficiencies. So those are kind of our biggies. But there's a list as long as my arms of acquired causes like diabetes and also hereditary causes like amyloid, amongst others. So what we use to try and help us, first of all, confirm the neuropathy, and also help us kind of go down the line of investigation of that neuropathy, are these nerve conduction studies. And basically what these look at is the kind of electrical responses in both sensory nerves and motor nerves, okay? So if the responses are slow, then there's a problem with the myelin, which is the kind of sheet that overlies the axon, and that's referred to as a demyelinating neuropathy. And these, by and large, are rare. And when we see a patient with a demyelinating neuropathy that's had a fairly quick onset, we will think along a certain line, usually of an inflammatory neuropathy that might require us to go in with treatments to suppress the immune response, for example. Axonal neuropathies, where conduction is absolutely fine, but the actual responses are small. So that indicates that there's something wrong with the axon, which is the inner wire of the nerve. So these guys are much, much more common with diabetes, alcohol, vitamin deficiencies, sometimes hematological malignancies being big and very common causes of neuropathy. And in fact, there's some schools of thought that axonal neuropathy is almost a consequence of aging, that if you do nerve conduction studies on patients over the age of 65, you will expect to see a bit of length-dependent axonal neuropathy. So when I'm looking at the report from the nerve conduction studies, I'm looking to see, is there a neuropathy? Is it demyelinating? Is it axonal? And then what are the nerves that are involved? Are the sensory nerves involved? Are the motor nerves involved? Are there a bit of both? Is it length dependent, like we talked about? Is it patchy? And after that, you can actually divide your causes. And again, we've got these big, long lists. And the thing about amyloid and hereditary amyloid is that it can actually present as a demyelinating neuropathy, and much more commonly as an axonal neuropathy. So there are amyloid patients, hereditary amyloid patients, who've gone through a career almost of being treated as an inflammatory neuropathy when actually they had amyloid all along, and probably not enough attention was paid to the other things that were going on, the autonomic symptoms and the cardiac phenotype as well. So the diagnosis of neuropathy, we'll use three main things. By and large, it's nerve conduction studies, and nerve conduction studies only in most of our patients, because we get an objective assessment of motor and sensory nerves. And this, by and large, is reproducible across different laboratories across the world. And I've already mentioned that these particular studies are not good at looking at small nerve fibers. And even when we can do skin biopsies, we're still not great at actually, counting those nerves. Now we can look for Congo red staining, we can look for amyloid staining, but, amyloidosis can be patchy, so you can't really pin all your hopes on a skin biopsy for a diagnosis. So with autonomic function tests, the issue is there's no agreed protocol between departments. Now we have a protocol locally. I'm not even sure if Edinburgh has, or Glasgow or Dundee, which are the other kind of major neurology centres in Scotland. And the testing that we do is almost certainly rudimentary compared to what's done in the National Amyloidosis Centre in London. And with autonomic function tests, you do need to take into consideration the effects of medications that the patient might be on. So the patient might actually be on, say, medications to help with the neuropathic pain element that could have an effect on the kind of responses that we would see with autonomic function tests, and also other medical conditions as well. So I'm not going to talk too much about hereditary amyloidosis because it's already kind of all been discussed and So you'll be aware that there is this kind of, we're kind of very much influenced by the Donegal influence in Glasgow, and most of our patients carry this variant, this T60A variant. My patients present to a variety of specialists, gastroenterologists, neurologists, cardiologists, and clinical geneticists as a result of someone in their family being diagnosed and that instigating cascade testing. It's rare in my practice, and certainly in the rest of our neuropathy team in Glasgow, for neurologists to make the diagnosis. The diagnosis is usually made by someone else. And as Caroline pointed out, patients can have a very, very long path, for that diagnosis to be made, and through either gastroenterology or cardiology or generalists. And often by the time they've developed the neuropathy, the diagnosis has already been made. So I've talked a bit about the small fiber sensory neuropathy. There isn't a huge amount of data in the literature, looking at individual TTR variants and matching that up to the type of neuropathy you get. Aisling Carr in London presented a series of patients. Again, we're talking less than 50 patients, and she found in those patients that had the T60A variant, that which was 13 out of 17 had neuropathy, which developed between the ages of 55 and 65. And these patients presented with numbness, and also when they followed them up, there was quite a change even within a year or two, in that these patients were accumulating disability. So by the time you have a neuropathy evident on nerve conduction studies, it will progress. What can be more commonly a feature in the T60A variant is the autonomic neuropathy with significant weight loss, and obviously the cardiology presentation as well. The type of neuropathy can vary across different TTR mutations. So there's the variant that's much more common, for example, in Portugal, where patients will present in their 20s and 30s. But we have seen, certainly in our cohorts, even within the same family, patients who are carrying the same mutation, the same variant. A brother might have a neuropathy and his brother may have no neuropathy. So there can be a huge amount of variation, which probably is explained by other genes either protecting the patient, or other genes just allowing the TTR variant to cause disease. So when we look at the nerve conduction study findings, classically, by and large, we're seeing an axonal neuropathy, and I've already talked about how that's the most common neuropathy that we see in the neurology clinic. But it can sometimes be patchy. Slowing of the median nerve, so suggestive of carpal tunnel syndrome, is very common and can predate the diagnosis by up to 7 years, which was in the London paper. We don't know necessarily if the carpal tunnel syndrome is definitely due to deposition of amyloid, because those patients by and large haven't had their tissue tested for amyloid, but odds are is that that's what's going on. And I also mentioned that it can look like other neuropathies. So sometimes it can look demyelinating, and patients can be misdiagnosed, which can be, in this day and age is a big thing, particularly in the COVID era. The last thing we want to be doing is to be putting patients on unnecessary immune suppressant drugs that could, increase their risk for opportunistic infections such as COVID. And often not enough attention in these patients have been placed on the autonomic symptoms. And it's up to us as doctors, as clinicians, to really kind of spread the word about amyloid and about asking about autonomic symptoms. And it can be uncomfortable in clinic, but you have to ask, and then looking for any kind of history of cardiac symptoms. So neuropathy in ATTR amyloidosis has been staged, and this staging system is 40 years old, so we probably are due for a bit of an upgrade here. And this is what is referenced in the two trials, and I'm sure will be talked about later. But by and large, most patients who were included in these trials had stage 1 or stage 2 peripheral neuropathy. So with stage 1 no help needed to walk, and mostly mild sensory or motor symptoms in the lower limbs. And in stage 2, people perhaps might need assistance walking, either with a walking aid, and the symptoms now have progressed to involve the hands. And then stage 3 is where patients are requiring a wheelchair to mobilise or are bedridden and have very severe sensory motor neuropathy. So the patients that were included in the gene silencing trials had Kuehne stage 1 or 2 neuropathy. And I suppose what's interesting as well to notice about these trials is that the authors didn't really comment on whether or not nerve conduction studies were abnormal in all of these patients, but they did score them on neuropathy impairment scores. And what they found over the course of time, now these are kind of fairly short studies, just over a year, was that there was a separation in the neuropathy impairment score and also quality of life, and this is reflected in both treatments. And I'm not going to hugely talk about these because I know there's a talk coming up, but essentially the patients who are treated, there's a difference, and I suppose the important take-home message is that these were patients who were determined to have a neuropathy. So on the basis of that and the fact that we were beginning to see patients coming through from the NAC, in Glasgow, we developed a protocol so that if a patient had neuropathy, we could get them put onto treatment quickly. And this took a long time. It took about 6 months between me, asking management, can I prescribe a gene silencer? And in fact, I was able to prescribe one about almost 2 years ago now, and that kind of went under the radar. But these treatments these are expensive treatments. So really, we have to be sure that we are prescribing according to the SMC guidance, which allows us to prescribe if patients have Kuehne stage 1 or 2 peripheral neuropathy. And I'm part of a neuropathy team that includes 4 neurologists based in the west of Scotland, and we came up with these guidelines. And really, it's to allow us to easily prescribe these treatments in a quick manner, and also think about when it's perhaps not a good idea, and also to think about those patients that don't have a peripheral neuropathy according to our criteria. What do we do then? So, for example, somebody that has perhaps small fiber symptoms, we would do a skin biopsy to look for Congo red staining, and then perhaps put in an individualized patient request form to essentially request to treat. But the treatment decision would be based on the individual health board of that particular patient. Whereas if you have a neuropathy that's objectively there on nerve conduction studies, the funding for the treatment will come nationally, and there should be no issues with that at all. I think it can be difficult in other centres now because these kind of protocols do not exist. And I've shared this protocol with other centres, and I think both myself and Caroline have engaged with other centres regarding our experience as well with prescribing these treatments. So to summarise, neuropathies have many causes, not just amyloid, and it is up to the neurologist to really kind of tease that out. And that's why when you come to the neurology clinic, you get hundreds of blood tests and lots of questions. And if we do find that the nerve conduction studies are abnormal and there's no other cause for the neuropathy, well, then there's a clear case to treat for amyloid. And we do have a local protocol, which was just approved in March of this year. So at least, going forward in Greater Glasgow and Clyde, we can access treatments quickly. It does have entry and exclusion criteria, and also stopping criteria too. So if we have patients who are entering, the palliative phase of their disease, ordinarily we would address, most of their medications that they were on, that and this would be the same as well, in that it's probably not in the best interest of the patient to be coming and putting a Venflon in every 3 weeks, as is the case with patisiran. So I'm going to leave it there.